Hello, everyone. My name is Jess Karen of Making Worlds Bookstore in Philadelphia, a city built on Lenape territory, and Common Notions Press. We'd like to welcome you to this discussion, From Crisis to a New Politics of Care. We'd like to thank our co-sponsors, the Boston Review and Verso Books, for helping to organize this event. And we're delighted to have the opportunity to hear from Emma Dowling, author of The Care Crisis, as well as Gregg Gonsalves and Amy Kapczynski, contributors to the Boston Review's The Politics of Care, From COVID-19 to Black Lives Matter. A year into the global pandemic, there couldn't be a more urgent time to have the conversation we're having today. Here on Turtle Island, we've seen the ways that structural and colonial violence have created ideal conditions for the virus to have devastating impacts on Indigenous, Black, and Latino communities, on migrants being held in detention centers, and on countless people who are imprisoned because of a racist and colonial criminal justice system. All of this, of course, is a continuation of the oppressive structures that have long existed. The fractures and failings of a privatized healthcare are ever more apparent in the midst of our global lockdown. And in all of this, enter questions about the politics of care. The books that are taking center stage tonight that I just mentioned a minute ago are available for Making Worlds Bookstore at the links in the chat. You can visit us at our bookshop page or on our website. Your support for collective nonprofit independent bookstores and publishing houses is greatly appreciated and politically, culturally, and economically vital to our work. You can also join our monthly sustainers program for both Common Notions and Making Worlds for $5 or more. I also wanted to briefly mention that while we're not discussing these books tonight, hopefully at an event sometime soon, so keep an eye out for that, Common Notions has also published 2 books that are related to the topics being discussed today, For Health Autonomy and Take Care of Yourself, and these are also available at Making Worlds Bookstore. So with that, I'd like to offer some brief introductions of our speakers before we get started. So Emma Dowling is a sociologist and political economist currently based at the University of Vienna. She's previously lived and worked in Britain and has been active in feminist and global justice movements. Gregg Gonsalves is an assistant professor in the Department of Epidemiology of Microbial Diseases at Yale School of Public Health, faculty co-director of the Yale Global Health Justice Partnership, a core faculty member of the Yale Public Health Modeling Unit, and a longtime advocate for health justice and access to medicines, both globally and locally. Amy Kapczynski is a professor of law at Yale Law School, faculty co-director of the Law and Political Economy Project and the Yale Global Health Justice Partnership, and a longtime advocate for health justice and access to medicines both globally and locally. We also have the pleasure of welcoming Matt Lord, Boston Review's senior editor, to say a few words about Boston Review and today's discussion. Just a quick reminder, we'll field questions and comments in the chat, so please feel free to type in your thoughts there. And with that, I'm going to turn it over to Matt.
Thanks so much. Let me begin by thanking Making Worlds for hosting this terrific event, Verso Books and Common Notions for sponsoring it with us at Boston Review, and Emma, Amy, and Gregg for leading this discussion on these urgent and really important issues. I just want to say a few quick words about who we are. Boston Review is an independent nonprofit space for discussion of the democratic life. All the essays on our website, including our extensive archive, are paywall and ad-free, and they always will be. We also publish several nonfiction books every year, mostly on left-leaning politics and philosophy. One of the books is The Politics of Care, to which Amy and Gregg contributed. Another is On Anger, which the New Yorker named as one of the best books of 2020. They're all available to order at our online store, as well as everywhere books are sold. Most of our support comes from readers and donors and from charitable grants. So if you enjoy this event, please visit our website, bostonreview.net, and consider helping out by becoming a member, making a donation of any size, buying a book, or signing up for our weekly newsletter. Thanks again, and I really look forward to the discussion. Thanks again.
Thanks very much. Thanks very much, Jazz, for your introduction. And thanks also, Matt, for being here and for giving us some background information about the Boston Review and the Politics of Care publication that my fellow discussants, Amy and Gregg, contributed to. It's a real pleasure to be joining you from Vienna. It's 10 o'clock at night here, so I'm a slightly different time space. The title of today's event is From Crisis of Care to the New Politics of Care, focusing on the UK and the US. And I'm really delighted to have the opportunity to be in conversation with Amy and Gregg about their work on the politics of care. And in the next hour, we'll be discussing three broad questions. First of all, what are the causes of the current care crisis? What can be done to end the care crisis? And also, what are the challenges in terms of movement building and affecting change? And we'll have about 40 minutes discussion between Amy, Gregg, and myself, and then we'll open up the floor to questions and comments. As Jazz said, you can put those in the chat box. Now, in the current context of the pandemic, it seems sadly all too obvious that we're talking about a crisis of care. Brought into view were the lack of resources and equipment available to health and other care workers, as were understaffing, long hours, and low pay in the care sector. The situation in care homes for the elderly has been especially troubling. During lockdowns, families had to turn their homes into offices, nurseries, and schools, with an uneven burden of the work involved falling on women. But not everybody was able to find a safe haven in lockdown, whether that was because they had to continue traveling to work, because they were driven out of the home by domestic violence, or because they did not have a home to go to in the first place. And exposure to the economic consequences of the coronavirus crisis has not been the same for everyone. Indeed, we also know the consequences of contracting the virus have been unequally distributed. In addition to factors such as age or pre-existing health conditions, socioeconomic status and ethnicity have also been shown to be significant factors. And of course, the desperate shortcomings of a just-in-time economy with few reserves were made evident. Now, I began working on the book The Care Crisis about 5 to 6 years before the pandemic began, and was quite literally doing the final edits of the manuscript in the first weeks of the pandemic. And so, obviously, for me, it was a sort of interesting moment with regards to having worked for a really long time on this issue of the care crisis, and it sort of bursting onto the scene and being something that everybody was suddenly discussing. But of course, COVID-19 has not so much caused a crisis of care, but highlighted its existence and exacerbated its symptoms. And my motivation for the book had been actually to make visible a growing care crisis that was there already, affecting more and more people, especially after the global financial crisis of 2008. And I'd set out to speak to different people in caring roles, those caring for loved ones and feeling on their own, junior doctors on strike over the devaluation of their work, migrant domestic workers struggling for recognition, people working in care homes facing the effects of privatization, social workers on the front lines of austerity in the UK, volunteers helping refugees and challenging who is cared for and who's not. And I wanted to make visible their realities, and I wanted to join up the dots between them and link them together into a bigger picture of the political and economic structures. And so focusing on the UK, because the book really takes as its sort of field of investigation the UK and Britain, I wanted to also point out that when we think about care, we have to think across different spheres of society that are normally not thought together. So paid professional care work, unpaid care work in the home, in communities, in activism, in friendships and families, but also the role of the state and the function of markets. And so that's really how I think we get a sense of what a society's care infrastructure is, as opposed to just looking at one part of it. Now, as I already said, by the time I finished the book, this care crisis could no longer be ignored. And what I mean by a care crisis, and not just me, but I think what we generally mean when we talk about a care crisis, is that the foundations of caring are being eroded. The kind of societal capacities for care are exhausted. There's an inability of people to access the care they need to live well, and the conditions under which people are providing care, both paid and unpaid, are increasingly difficult. But also at the same time, care needs are increasing, particularly due to demographic changes like aging. But vulnerability is socially and economically produced by a system that is orientated towards simultaneously exploiting and depleting our caring resources. And in particular, the idea of cost saving, whether that's to facilitate wealth extraction or whether to operate under conditions of austerity, means that reserve capacities are depleted. This makes the care infrastructure fragile and vulnerable to unexpected events like the coronavirus pandemic. And Amy and Gregg, in their text, The New Politics of Care, call this the genuflection to fiscal conservatism as a marker of policy seriousness, which I think captures the entanglement of austerity policies with the ideology that serve its legitimation very well, that there are no alternatives to funding cuts for public infrastructures, that there is no money in the pot, that not embracing an austerity is in fact somehow a marker of recklessness, when the impact that austerity policies have had on people's lives shows us that the opposite is true. Now, in the UK, particularly after the global financial crisis after 2008, there were significant austerity measures. We saw an increase in inequality in access to care, a rise in informal care, and a deterioration of conditions under which carers work. There were cuts to social security, so a restructuring of social security in terms of cuts to in-work benefits, disability allowances, also a series of regressive tax reforms which really sort of moved wealth upwards. Also, cuts to local authorities were significant. Local authorities in the UK are the local councils that are also responsible for providing social care in particular, along with other services. And here, budgets were cut up to about 60% over the last decade. And of course, the poorest areas experienced the worst effects of this. And local councils simply didn't have enough funds to provide adequate services. And I should also say that in the UK, healthcare and social care are funded separately and are not in the UK, in England in particular, and are not integrated. So local councils are responsible for social care, care for elderly, also people with disabilities who need care of some sort in their everyday life situations. So this was sort of very specific to the austerity measures that happened. But also the other thing is, of course, the primacy of waged labour. And at the same time, of many years now, what we've been seeing is a wage stagnation. So it means more income needs to be earned in the household, and we have a sort of dual earner model with both. You have two, household with a family would have two partners working. More women enter the labour market without a kind of significant change to the sexual division of labour, and so we have this kind of primacy of waged work, which also means that there is less time for people to actually care for themselves and for others. And when also with the austerity, the work of caring is further offloaded onto unpaid realms. So where cuts happen and services are not available, then that work has to be done by people in an unpaid capacity, whether that's childcare or caring for loved ones in whatever way, but also getting involved in communities and neighborhoods and helping out there. So austerity and the work of caring is offloaded with austerity, mostly to working class women and people of color, while the affluent can buy themselves out, of course. The other issue that I just want to touch on briefly is also privatization. And privatization is also something I look at a lot in the book, and particularly also the development of markets for care and sort of new processes of financialization as well. And I don't really want to go into too much detail, but just to say that introducing the profit motive and corporate models designed to reap profits by introducing economies of scale has, of course, devastating effects, particularly in areas like social care, where economies of scale are hard to achieve. You can't expose a labor-intensive, low productivity sector like social care to market forces without having to find ways to generate profits for shareholders. And that happens so often by cutting pay and conditions for care workers and finding ways to keep costs down. But of course, when things go wrong, investors protect themselves from exposure to risk through financial engineering, leaving care workers and care recipients to bear the brunt of crisis, as we've seen again and again. Now, one central aspect here is that the unpaid and underpaid work of caring and of social reproduction, that is, of life-sustaining activities that take place in households and communities and neighborhoods, but also in hospitals, in care homes and other institutions, is undervalued or not seen as productive activity, even though it constitutes the very condition for any kind of economic activity at all, let alone life itself. Moreover, in the context of a capitalist economy, social expectations around whose role it is to care, gender obviously playing a significant role here, but also labor market vulnerabilities like class, migration, background, and ethnicity are instrumentalized to exploit this labor and keep its costs as low as possible. So Amy and Gregg, you make a similar point in your Boston Review article, The New Politics of Care, when you point out that during the pandemic, millions of people in the US displayed remarkable care for friends, families, and neighbors, enacting social solidarity in the absence of political leadership. But that what you say is the economy that we're offered in the usual take, measuring little and commanding much, does not value such activities. Staying at home is not a productive activity. Would you like to come in on this point here in terms of the current care crisis in the United States, exacerbated by the pandemic and the deeper roots in the political and social order that you see as central to its shape and also to its urgency?
Yeah, thanks, Emma. That was a wonderful beginning of a conversation that I've really been looking forward to, and I know Gregg has as well. So I think we do see very similar themes to what you're describing in the US and connect them very much to why coronavirus has been so incredibly deadly here. And the crisis has reached so deep and revealed so much that was in fact already going on before it. So, you know, you're talking about the UK, we're talking about the US, but we could say almost different details, but it's going to sound the same notes, right? So, you know, we are far worse than I think your circumstance with respect to the number of people who simply lack health insurance, the number of people in detention, detained whether crossing borders or incarcerated. We have long had deep racialized health inequities that have been very much part of COVID. We have austerity has ravaged our public infrastructure. And so, for example, in public health, if we wanted to have in the United States the same number of public health workers that we did in 1980, we would have to triple the number of public health workers that we would have in this country. Just since the financial crisis of 2008 alone, we've lost 25% of our local public health workers, right? So we have absolutely taken apart our public infrastructure, particularly since the financial crisis, but really since the 1980s. And we have enormous problems of the kind you describe with respect to the power of workers over their working lives, which has caused acute problems, for example, in our nursing homes, with the attempt to sort of casualize the nursing home workforce and not give them the ability to either care for people in their care because they're working with too many patients and too few resources. Of course, in the pandemic, that meant without PPE and without adequate ventilation and really in terrible conditions. And that, of course, has had a terrible impact here on the pandemic side. So, in general, the United States is notable for how, we don't even have paid sick leave. I mean, we have really so little social infrastructure, and that infrastructure itself has been taken apart. So, Gregg will probably say more about some of the particulars of our circumstance here in the United States with respect to the lack of real respect and in fact enablement of care and the way that really came home during coronavirus. But I think I wanted to step up a level of generality and say, why are we telling the same story, even though we're talking about really radically different societies in parts of the world, right? And I think that's because the ultimate root of what we're talking about really has a conjoined, well, I understand them as the product of essentially a kind of neoliberal capitalism now that operates systematically in a certain kind of way. And so you see differences in its implementation in different places, but systematically a degradation of our forms of social relation and forms of care for one another because they're not well compensated by the way that we have come to treat both the state and the market. And so when I say neoliberalism, what I mean there is a kind of reigning idea of how government should work and how markets work, which has really predominated in many, many countries around the world, and that has had an international dimension. The work that I do on law and political economy, we have mapped, and I could tell you how neoliberal ideas, these are ideas, for example, that the market is efficient, that we need to liberate it, that our goal should be efficiency, and that we should use markets to discipline society, in effect, to render ourselves more logical. These are sort of a very technocratic kind of utopianism in this kind of neoliberal idea, and that fundamentally, I think, is an idea that is using fundamentally sort of attacking democratic structures and attacking ideas of fair distribution by insisting that markets actually predominate over politics and over society, when in fact we know that markets are embedded in society, and we can tell why. Well, so one manifestation of this, and that Gregg and I were talking about in the piece that you mentioned, is that the idea of staying home and taking care of our loved ones just registers as economic collapse because people aren't going to work and they're not shopping. And so the same work that you do outside of the home, if you bring it inside of the home, someone's teaching your child outside, you're teaching your child inside, doesn't register because economic statistics don't count that as work if it's done inside of the home. And if it's uncompensated, of course, a great deal of care work is uncompensated. And the care work that happens in the market is typically poorly compensated. And feminist economists and social reproduction theorists tell us lots about why that is. And so we're sort of drawing on that literature and those ideas that care work is systematically, in fact, extracted by a system that doesn't pay for it, typically much of it at all, and that a great deal of it, in fact, is kind of coerced because it's expected socially or otherwise, and it's imposed upon disproportionately people of color, and women, of course, and it is neglected in these structures. And so the same difficulties you talk about in your book, precarity, right? The fact that we're now requiring just-in-time kind of work and things like that. Those are another way that the kind of imperative to serve the market cannibalizes what in fact it means, the texture of our lives together, what it means to be a person in caring relationships with others. So I know we'll go on and talk a little bit about what we might do about this, but let me hand it off to Gregg now after those sort of remarks.
Hey everyone, hi Emma and Amy. So I want to talk about the stories we tell ourselves. So last year, many of us stayed home, and even I described it as an enormous case of social generosity, that we were protecting our neighbors and our friends and families by staying home if we could to keep SARS-CoV-2 from spreading through our communities. And my question is what kind of myths were built around that sort of act of personal generosity that we did last spring, and we continue to do, many of us, in places hard hit by the epidemic. One is that the notion of charity, of mutual aid, of volunteerism is the way to approach public health crises, right? And that in the absence of the state, we can fill in for each other, right? In an austerity ravaged era, all we have is ourselves, which sounds wonderful, but it's basically the same thing as saying you're alone against the virus, right? The other myth I think that really occurred to me last year is that we had a strong temptation to blame Donald Trump here, and we blamed Boris Johnson to a little less extent, but Boris Johnson, Bolsonaro, other people around the world who've had terrible leadership in terms of the epidemic, we had a tendency to blame these political actors, contemporary political actors, for our problems today. And one of the things that Amy and I talk about in our pieces, and we're teaching a class now on COVID-19 health justice theory to practice, is that you need to look much, much deeper in American history and the sort of history of race in America. There's a book that we had students read a chapter from in our class it's Jim Downs' book called Sick from Freedom, African-American Illness and Suffering During the Civil War and Reconstruction. And the idea was that federal policy on health reflected white ambivalence at every turn. And Jim Downs talks about this idea of Black extinction, where white legislators were arguing that free assistance of any kind would breed dependence, and that when it came to Black infirmity, hard labor was a better salve than white medicine. No charitable Black scheme can wash out the color of the Negro, he quotes, change his inferior nature or save him from his inevitable fate. Fast forward and you have Alex Azar, our Secretary of Health and Human Services, suggesting that it's the poor health of communities of color that are to blame for deaths from COVID. It's nothing about our history and our public policies and our politics. It's all about this idea that a theory of Black extinction, which is resurrected from the Civil War and brought all the way into the 21st century. And so, we're talking about the crisis of care, we're talking about the role of the neoliberal state, but race is a huge piece of it, at least in the American exposition of it. There's no compulsory health insurance in the USA. African Americans were excluded from New Deal programs and social welfare programs that came out of the Great Depression. When we tried to extend rural hospitals into the American South in the 1940s and 50s, it was only done on the condition that Southern governors could decide where those hospitals went. National healthcare has been called the Prussian menace or the Red menace. It's about American history. And when we look at Medicaid expansion refusal in the Southern states under the Affordable Care Act, those same sort of antagonisms are as live today as they were in the 1920s, 30s, 40s, and 50s. And so we have a fractured patchwork of a healthcare system that left millions alone against the virus, as Amy and I say. But basically it's based on the idea that the safety net that people were shredding in the 80s, whether it's Ronald Reagan or Bill Clinton, it was always for somebody else, somebody darker at a distance and less deserving. And as Amy knows, and all of us know that people who can't get care earlier get sicker. Delays in care mean more infectious people in our communities. I'm talking as an epidemiologist, and further spreads the virus in our communities and overburdens the facilities that care for them. So if racial capitalism drove a care divide across American history, a medical apartheid in the US, the 80s and 90s, and I think Emma's talking about this, the rise of Thatcherism and Reagan drove a new rabid version of this divide, right? If there was a divide based on race throughout American history, now care is privatized, surrendered to the market. It's made a commodity available to the highest bidder, and nobody's safe now. Color does not protect you unless you bought a ticket to safety. And even in the context of COVID, we've seen that it's uncertain that safety applies in the context of a collapsed health system and a social welfare state in this country.
Thanks, Gregg and Amy for your comments. I wanted to perhaps just pick up on one of the points here, because I think there's a lot that you mentioned, but also in your article, you also talk about how the US is one of the most technologically advanced healthcare systems in the world, but it's unable to provide care for all. I was wondering whether you could just explain that very briefly, like what's up with that? Like why does that happen? Why is there such a discrepancy? Like what are the structural conditions that produce such a contradictory outcome?
So we spend the most on healthcare in the world, but we have life expectancy in the 20s and 30s in terms of world rankings, comparing us to other countries. And there's lots of reasons for it, but one key one is we put a lot of emphasis on tertiary care, sophisticated end-of-life care, specialty care, to the detriment of primary care and preventive care. Right, it's the specialty medical fields that are the most lucrative for those who do the research and care in them. So that's one piece of it. But Betsy Bradley, who used to be a professor here at Yale School of Public Health and is now the president of Vassar College, did a book called The American Healthcare Paradox several years ago, and she said, let's look outside of health at social welfare spending in the United States, and that's where you see the disconnect between our peer nations in the United States. All the things that we would consider the social determinants of health that other social welfare states sort of undergird and support, the United States makes no investment in it, whether it's housing or daycare or early childhood education. We do not invest in it. And the thesis in her book is that this is what's at the root of the sort of American healthcare paradox, and the fact that we spend a lot on health, but we get very little back in return.
Mm.
I think another way to think about this is that we're, American political culture is kind of technology obsessed. And that I think has to do with the underlying politics that Gregg and I are talking about. I mean, who benefits from our obsession with technology? We spent billions and billions of dollars, much of which is going to basically redound to the benefit of a few drug companies to get the vaccines kind of accelerated through the process that we have. Lots of federal money into research, which we should all be very, very grateful for, and played a tremendous role in getting the vaccine candidates that we have to market. But I think more broadly, the kind of racialized history that Gregg is talking about have kind of, on the one hand, played a tremendously big role in our lack of welfare state, and that some of that has gotten built in through the back end by medicalizing problems. Because in fact, when you medicalize problems, it still turns out to be largely, I think, elites and largely white people who control what solutions count and whether or not, and sort of generate some kind of argument for making exceptions to the general bootstraps kind of. There is a tremendous politics of healthcare access in the United States now, and the results of it are pretty terrible. The results of this way of allocating attention and care are pretty terrible, and it does still mean that, of course, those high-tech interventions don't get to everybody in the same way. And of course, we could tell that story just by talking about the COVID vaccine alone, right? Mm-hmm. We have the vaccines, and they're still, if you look state by state, we haven't even. It's actually not easy to get the data, but we know that the people who are most vulnerable, and particularly in communities of color, are not getting the vaccine to the proportion that they need it. And that is in part because we have not enabled infrastructures that allow care to be delivered equitably. And that's in part by design.
Mm-hmm. I mean, I think that's a really significant point that you mentioned there also about the focus on tertiary care and the lack of focus on primary care. And I think also in the UK, one of the issues is also that social care, like healthcare, is something that receives not enough, but more funding than social care. Social care seems is sort of the poor cousin. Which I also think is a kind of important aspect also when we think about, if we want to think more holistically about care and what is needed, then it seems interesting to me the way that capitalism is able to sort of siphon off these different aspects and is able to provide one but not the other, and therefore also two specific groups and classes and not others. And obviously all sorts of issues play into that. But so that's one thing. And the other, I guess, is it's also this question of, okay, so there are the attrition of actual collective infrastructures, and that is the welfare state, but also actually a way of having a care infrastructure that is there for everyone is something that, of course, now a lot of people are talking about. And in the UK, one of the trade unions organising with health and social workers has the slogan, "There is no going back to normal." In other words, while many long to get back to the normality post-pandemic, that's not an option, because what passed as normal prior to the pandemic was already in crisis. So, and I think what's interesting to me also is that you point to the ways in which volunteers and volunteering, on the one hand, social solidarity is a really good thing, and this is something that we need, but at the same time, we can't rely on a system that falls back on volunteers. And I think certainly the Thatcherite agenda is a conservative ideology that you are responsible for yourself or your family or your charity or the people that you choose to be to care about and care for, and there's a sort of really kind of regressive Victorianism that also plays a role and comes to the fore here. And I think to me that was also very striking, because in my book I look at some of the different ways in which unpaid care work is sort of siphoned off also to volunteers in different ways, whether that's food banks, that then people who are affected by austerity find themselves having to use food banks. Those are run by volunteers. In hospitals, volunteers coming in to help out and sort of be there for patients in different ways, so that the healthcare workers can focus on the medical tasks. But of course, the backdrop is scarcity of resources and paucity of time. So there's a real way in which that kind of volunteering becomes something that's plugging gaps, and also it can't be relied on because by definition it is voluntary. So I guess the question is, if on the one hand we want social solidarity, also self-organization of communities is empowering, these are things that are good things, but at the same time we also don't want a situation where we're relying on volunteers, and certainly not in that kind of conservative idea of charity, and those who don't have it just fall by the wayside. So where are we going? So how do we collectivize care? Because we know that's also, I mean, you talked about efficiency, which I thought was also, you also talked about how in the US, like, there is lots of spending on healthcare, but it's an incredibly inefficient system, because actually relying on, for each individual having just to provide for themselves is actually not that cost effective. So I guess the question is, what are we going to do? Like, how do we build a collective infrastructure? And so I wanted to ask you, really, where do you see the sort of openings for change, or what's the agenda that we should be working towards now?
I mean, what we've been thinking about, I think Gregg and I, has to do with how you build a politics of care. And that has to do, it can involve forms of, let's say, mutual aid. But the mutual aid that I think I find exciting is the kind that is providing mutual aid as a part of a kind of integrated organizing effort. And so there are groups that were doing this and that are doing this, that are seeing the opportunity, much the way that, for example, the Black Panthers did in the United States when they organized they were actually created the prototype for the free breakfast programs in schools that are now run, and they provided free healthcare clinics, but they didn't do it because they thought, let's provide the services that the state isn't providing. They did it very explicitly as part of an organizing effort, as a part of a means of reaching people, of embedding a vision of how the world could be different, what it would mean to actually care for one another, for people to have care without being, without money exchanging hands at the clinic or for breakfast. And it was always integrated as part of a movement building idea. I mean, I think our own instinct is that without movement building, and again, we're speaking very much from our kind of local context, and I think everybody needs to, in the sense that these movements, if we're going to build a politics of care that are going to change how we operate at the level of sort of how our political economy is organized, so changing laws, changing government policies, that all of those are going to need the kind of energy of political power building. And so we also have focused on and do a lot of work now with our own labor unions and community-based organizations that have power building models at their core, with the thought that unless we build power, we will not be able to make political change. And so we read and sometimes teach about ideas of sort of non-reformist reforms. How do you, borrowing from abolition and work on defunding the police in the United States, for example, where that language is very common, that what we should aim for is not reforms that simply minimize suffering, but reforms that are going to actually change the power dynamics at the next round of reforms. And so that you're building power within communities for people then who are most affected to come and speak to what the next set of changes need to be. And that, if you take that approach, I think it gives you both a perspective on what the value of mutual aid is, that's a little bit different than simply volunteerism and getting the job done, right? And on who and how we ought to work and think about. And that might help you distinguish between forms of also government programs that we ought to invest more heavily in, right? Ones that will sort of really make evident the role, Gregg and I, in part of the Boston Review pieces that you've raised, talked about building a community health corps, right? A government federally funded and locally implemented corps that would really be a visible manifestation of what we can do to care for one another, so that you wouldn't have the circumstance that we've had in the United States where, you get a phone call from, here in Connecticut, our contact tracers were all volunteer for a good portion of time, right? You get a phone call from some volunteer who may not speak your language and who cannot help you and simply tells you, oh, now you should isolate yourself. And you say, well, who's going to take care of my kids? And they say, I'm sorry, I can't help with that. Rather than that, you have somebody who, in fact, is connected to, maybe comes from your community, is connected to all kinds of other resources, and that actually helps you get masks, that helps you get the care that you need. And that is both a visible manifestation that government can actually work for people and meet their needs and is not merely a kind of predatory, which of course in many communities it in fact has been and continues to be, with another police killing yesterday in the United States. So the need to use a vision of care being able to be delivered in this way. And you also need to build power in communities that are really made vulnerable by the legal and political choices that we've made.
I mean, I would add that we also have to think about how do we change how people think of the idea of the state as an actor in our lives. I mean, not to keep harping on Reagan and Thatcher, but Reagan said the 9 most terrifying words in the English language are I'm from the government and I'm here to help, right? And we have to put a stake to the heart of Thatcherism and Reaganism, and also Blairism and Clintonism, which is basically appeasement of the sort of notion of austerity politics. What's interesting and what's happening in the United States right now is that Joe Biden, the new president, who, frankly, I thought is a milquetoast centrist in the mold of his predecessors, has, just pushed through a enormously large relief bill and is asking for, several $1 trillion more in infrastructure with potential more to come. That is unexpected, but it's also a battle we have to win, because if these investments in the state, whether it's about pandemic relief or building up American infrastructure, which has been crumbling for 50 years, is that we've shown that the state can work for people. We've been told by Reagan and Thatcher and Blair and Clinton that it doesn't work and that the market will provide. And the political struggle now has been joined by the Democratic Party. I don't know if they can pull it over the finish line, but there's a lot at stake in American politics that, wasn't even conceivable under Obama, several years ago.
Mm. But I guess the question there is then also how to develop infrastructures that have necessary resources. So there is obviously an aspect there of sort of wealth distribution, and particularly I think also an honest conversation that there is no win-win situation, in the sense that we can just keep cutting costs and making things more efficient and then somehow people be cared for. That actually we need an honest conversation about the fact that more resources need to go into these areas of care, and that's a political question. And there's no sort of skirting around that. I think that's an important aspect. But the other one, of course, is also how to have a care infrastructure that is, if there is a necessity for public institutions and funded ones, but that's not something that's top down, and also not disciplining, not controlling, and not punishing, as you also say. And how, are there sort of ways in which we could have we can think about the sort of innovative models also on a local level that bring together sort of municipalities with worker organizing to actually think about different kinds of models. I mean, I'm also quite intrigued by say community nursing models that really try to think about how things like home care could be provided in ways that are self-managed by the workers who provide the community nursing, so nurses and healthcare workers themselves. But also one of the interesting things that, for example, community nursing organizations like Buurtzorg have been doing is sort of challenging the idea also of the division of labor around sort of expertise and the hierarchies within the organization, so that actually the way that then the care is provided is also different. So challenging ideas of sort of service provision, thinking about things like co-production between the sort of different people, caregivers, care receivers, and both paid and unpaid carers who are involved. So I think also these kind of thinking about, how do we build power, but also how is that also part of innovating different kinds of care infrastructures that are nonetheless also connected to funded infrastructures. I think that there's something there that's really, really generative, I think. And certainly also in Europe and in the UK, there are people who are trying to think in that direction as well. But I really liked your focus also on kind of power, like building power, because it's also about actually thinking about not only the care needs, but also, who is providing care and how and under what conditions. So I wonder, perhaps to wrap up our discussion, sort of what are the kind of hurdles or biggest challenges? Maybe actually reduce it to the one. What's the biggest challenge, would you say, to actually movement building and building this collective power to have a better care infrastructure, in your view?
Greg, do you want to take that one?
So look, Amy and I have been part of access to medicine movements from ACT UP in the United States to global access to vaccines at the current moment for COVID-19. And the assault on unions in the United States and also in the UK has been devastating to organizing at the most fundamental, basic level of the workplace, right? The sense of the lack of possibility, that you can escape sort of the clutches of the market, I think have made people dream small for many, many years post-1980s, 1990s. I think what you see with the rise of Bernie Sanders and Elizabeth Warren to some extent is that maybe that somnambulism is finally shaking off, and people are realizing there are alternatives to the sort of neoliberal market and sort of racial capitalism. The Black Lives Matters movement sort of starts to show this as well, and maybe we're at a turning point. But we've had an assault on our ability to organize in the United States, and we have to sort of retrieve it. And look, lots of things were accomplished with small bands of people in ACT UP and other places in the work we did. But really, we need a mass movement to sort of challenge the sort of hegemony of the right in the United States, for instance, that sort of set us up for the great fall that we had in 2020 with COVID-19. It's going to be, it's interesting. Philanthropy poured a lot of money into the democratic movement in Brazil after during the fall of the dictatorship and the attempts to topple the dictatorship. A lot of that movement building was very successful in setting up the national healthcare system in Brazil, the sanitarian movement that also ended up being able to provide AIDS drugs to people when they were not available in other places in the global South. So investing in organizing from philanthropists and others, taking the brakes off unionization and other forms of social organization that have historically been routes to power is where I think I would go at the current moment.
Yes, I mean, I think that's a view we share, right? That it's really in the kind of day-to-day work of organizing that we really need to invest. That said, I think there's also organizing in a way that does rebuild some sense of trust that, in fact, politics and the state can, in fact, solve some of the problems that we see before us. And some of that is about better highlighting the ways in which it does, right? I think, the vaccines are a great example, right? I think many in the public see them as a triumph of the private sector, and that's not the case. We're not very good at telling our own stories. And so figuring out how to connect some of the things that government does well in the United States, to sort of help rebuild a sense that this leap of faith is not entirely unjustified, is part of what we also really need to do.
Mm-hmm. Yeah, and I think also one of the things, certainly in the UK and here in Europe, one of the big discussions has been around the state and the role of the state and public funding, and a lot of talk also about the need for better care infrastructures. But I think at the same time also one of the things that occurs to me in a lot of these debates is many a time it's geared towards sort of thinking about how to put those have funding and put those structures in place in order to get the economy back on track, enable also particularly when it comes to unpaid care, enable women to participate in the labour market, to have an infrastructure that sort of supports capitalism and supports sort of things continuing and capital accumulation continuing, etc. So I wonder also about how we push and perhaps we stop there and bring in some questions, but I think it is important also to push for also more time for care, for a system that is not simply just geared towards putting the economy back on track, but actually also thinks beyond, so that actually care and the things that sustain our livelihoods beyond simply being posited as labor power for capital are really at the heart of our struggles as well. I think that's also something that really matters, and certainly coming out of some of the debates that are going on here, it seems to me that that's also where I think a kind of radical voice is also needed, so that it goes beyond simply just sort of patching things back up together again and putting the infrastructures in place that are necessary for capitalism to get back on track after the pandemic. Wow, we've spoken now for 50 minutes. I'm sure you probably want to perhaps come back on that.
Well, I just wanted to say one thing beyond that, which is that, Gregg and I came to know one another through our work in transnational networks. And I think that one real problem with the current moment is in our transnational connections and sort of rebuilding a kind of, there's pieces about the way transnational finance works, about the way that our kind of financialized kind of capitalist architecture works that the sort of, I've been very heartened recently by conversations about, that are happening at the highest level of US government now about creating a global minimum corporate tax. It's really, I've been teaching a little bit about the law of money and, understanding deeply how problematic our global architecture of money and finance is, and how much that in fact constrains states, particularly some states, in terms of what they feel able to do in terms of reinvesting in care. I think there really does need to be more dialogue, and I think one of the encouraging things is that movements in the United States that do care about care are becoming aware that the way that, for example, quantitative easing happens through our federal, our federal banking infrastructure and the Fed here, that actually has a huge impact on inequality, on what resources are available and who benefits. The fact that our stock market has continued to rise in this moment, right? That the way that these kind of decisions are being made that are cloaked and obscured by enormous kind of technical language, connecting up that to the kind of politics of care, so that we are aware and able to advocate at that level as well, seems like it's going to be really important, as well as working across borders.
Yeah, and I think also precisely because I think in the wake of coming out of the pandemic, also financialization is going to pick up, and particularly the interest in care is also going to pick up. So I think understanding those mechanisms and connecting up the dots is really important. I would agree. Should we see if we have any questions from people who have been watching and listening to us? And Amy, I also know that you might have to head off in 5 minutes, so feel free if you need to go, feel free to do so, please. And then we'll see if we have questions or comments from people who have been listening or watching. Do we have questions or comments? Okay, so one question is, how do we prepare care politics adequate for climate catastrophe? Now, I think that obviously they're bringing together this question of the climate crisis and the care crisis is really a significant issue. I think the one way that I would answer that question is in terms of thinking about. I think there's a sort of common thinking around care. And social reproduction, and putting those aspects really central to our organizing and connecting that to what the limits of our planet and the necessity of living differently. And I think it's sort of thinking those two together is really important. Transforming the economy in ways that is ecologically sustainable as well as socially sustainable, I think go hand in hand. So I think at each moment, it's also about bringing those two together. And of course, the better care infrastructures we have for one another and the environment, the better we will be prepared for what comes. But Amy or Greg, I don't know, do you want to comment on that question at all?
I mean, I think the Green New Deal conversation here has been an attempt really to integrate conversations about care for the planet and care for one another, and build a politics that could, in fact, not drive a wedge between, say, the labor movement and environmentalists by stressing that especially by emphasizing care, there's no need for green policies to be policies that would, drive up unemployment, and that we could work better, provide more care in ways that are not environmentally damaging, by centering care, and particularly low-tech forms of, you mentioned community nursing and community healthcare workers, right? That is actually where the best value is, if you want to talk in those terms, to sort of improve people's lives. And, I think there's a way in which the logic of care actually extends and connects quite beautifully our experience as humans and our relation to non-human animals and the planet, right? And that an ethic of care is a logical way, in fact, to talk about why we need a planet and why climate ought to be at the center of our politics going forward.
Yeah, the only thing I would add is that we need to strengthen numbers, and this is about community organizing and tactical decisions. The resources arrayed against us in terms of the corporate state, which created a care crisis, or also created an environmental crisis, we're going to need to build coalitions. And Amy's talked about transnational coalition building across care and health, but we need to do it across issues in which the neoliberal state, white supremacy, et cetera, are really primary actors in driving the problems that sort of crisscross the globe.
I mean, I think it's no accident that the question that has come now from people watching and listening is about the integration of ecology with these questions of care, because I think it's absolutely where we need to be thinking. I don't think we have any more questions. So I think at that point, it means that we actually managed to, we do have, thanks for the talk, as a healthcare student. What can those on the front lines be doing towards these ideas?
So organize other healthcare students, right? It's get a group of your friends together and start plotting your actions. And it can be at your local level, your provincial level, or your national level, or your transnational level. Point is, I mean, many of us who've done activism started at your age, right? Started as students and have kept it up over the years. And so there's no time like the present. You don't need to get your medical degree or your PhD or any university degree. You don't need any degree whatsoever to do this. And so I'm very much in seize the moment and get involved and find places in your community where you can make a difference. Not yes in mutual aid and volunteering, but really about political organizing and building power.
And also questioning perhaps the what it is that is taught on healthcare programs. I think there's also the sort of link to sort of questions of knowledge production as well, in terms of what knowledge is taught, whose knowledge counts, etc. Like, I think those are also questions and thinking about, particularly when you're in a kind of educational environment, also thinking about and questioning the sort of dominant narratives of what's being taught, and sort of trying to expand also beyond that, and sort of radical histories of healthcare and different knowledges, bringing that in, and also demanding that is something that is taught on your programs. I think that's also another aspect that as a healthcare student I imagine could be useful and rewarding and empowering as well. Okay, I think that was the final question. So I will return to my wrap up and just say thank you very much, Amy and Gregg, for being in conversation with me. I think we sort of touched on so many issues that we could have really gone into much more depth, and I do hope that we are able to continue the conversation, and I do hope that this conversation about care that has really picked up also now in the last year continues, and that we build power and continue to organize, and that we can affect change. Thank you very much to the two of you, and thank you to everybody who's been watching and listening, and onwards.
Our organizers. Yes, thanks so much. Okay, thanks everybody.
Thanks, Emma. Thanks, everybody.
Bye-bye.